Okay, so if you're ready, I'm starting the timer.
Yes, ma'am, please.
I've started the timer and here is the question. Right, so if you have read and understood, I would want you to tell me. Right. If you can
Yes, ma'am.
if you can look at picture C and tell me how the shoulder joint is formed.
Yes, ma'am. Actually, the shoulder joint is formed between the head of the humerus and the glenoid cavity of the scapula, ma'am.
Okay. So if you come back here and look at the picture A and tell me
Yes.
what is which bone is this of which side?
Ma'am, yeah, ma'am, it's possibly the left-sided scapula, ma'am.
All right, good. Can you identify the structure number 2 here?
Yes, ma'am, it's acromion process.
Very good. If you can identify 15 here in picture A.
Ma'am, it's supraspinous fossa.
Yes.
Yes, ma'am, it's supraspinous.
What is found here in supraspinous fossa?
Ma'am, the origin of the supraspinous muscle, ma'am.
Good. And if you can please identify number 5 here. Where is my cursor? Yes.
It is infraspinous fossa and origin of infraspinous muscle.
Very good. Okay. Coming here to picture B, if you can identify what is here in number 11.
It's, ma'am, subscapular fossa, origin of the
Yes.
subscapularis muscle.
All right. Good. Okay. You told me how shoulder joint is formed. Can you tell me what gives strength? What strengthens the shoulder joint?
Ma'am, the strength of the shoulder joint is mainly dependent on the rotator cuff muscle.
Yes.
That will be subscapularis, supraspinatus, infraspinatus, and teres minor. And also there is
Can you please tell me
ligaments.
the origin and insertion of all the rotator cuff muscles and their nerve supply, please?
Yes, the origin of supraspinatus and infraspinatus is from supraspinous and infraspinous fossa of the scapula, and insertion will be in the greater tubercle, and the subscapularis arises from the subscapular fossa, and it inserted in the lesser tubercle of the humerus.
Yes.
And the teres minor arises from the medial border of the scapula, and it inserted in the, also in the greater tubercle.
Okay.
And
what are
their
their
nerve supply?
Yes,
nerve supply, ma'am, supraspinatus and infraspinatus is supplied by suprascapular nerve, and it arises from the upper trunk, and the subscapular is supplied by the upper and lower subscapular nerve, and the teres minor is supplied by the axillary nerve.
All right. Can you please tell me what leads to decrease of the stability of the shoulder joint, or what causes reduction? Yes.
Yeah, there are several factors like shallow glenoid cavity, lax capsule with fewer ligaments, and inferiorly it is deficient because of presence of the quadrangular space. That makes it more vulnerable.
What is quadrangular space? How is it formed, and what does it contain, please?
Yes, ma'am. The quadrangular space is formed by at first, ma'am, superiorly by the lower border of the teres minor, inferiorly by the upper border of the teres major, and medially by the long head of the triceps, and laterally by the shaft of the upper part of the shaft of the humerus or neck of the humerus. And it contains actually, ma'am, the posterior circumflex humeral artery and the axillary nerve.
Yes, vessels.
Yes,
vein is also there. Very good. Okay, very good. All right. Can you tell me what are the movements which are present at the shoulder joint? And
The
which
movements
muscle
are
is
flexion.
responsible for which movement? Yes, please.
Yes, ma'am. There is flexion, extension, abduction, adduction, internal rotation, external rotation, and
Very good.
circumduction.
Yes.
So flexion is mainly performed by the ma'am, the a part of the pectoralis major, and also also it is done by the anterior muscle, the subscapularis, and the abduction is mainly performed by like 0 to 15 degree by supraspinatus, 15
Yes.
to 90 degree by deltoid muscle, and above 90 degrees
Yes.
serratus anterior and the trapezius and serratus
Trapezius.
anterior.
Yes.
And
Very good.
extension is mainly performed by the posterior muscles like teres minor and teres minor, latissimus dorsi, and there is adduction mainly is performed by together with pectoralis major, latissimus dorsi, and also the other muscle like teres minor, teres major.
All right. Very good.
And
Thank you.
also, yeah, ma'am.
Can you tell me what kind of imaging are you looking at?
Ma'am, it's the MR arthrogram oblique coronal view, ma'am.
Very good.
Of
Can you
shoulder, yeah.
identify the of the shoulder? Very good. Can you identify the structure 1 to 10, please? What is 1?
One is ma'am, yes, one is ma'am acromion process.
Yes, please.
And
What is 2? 2 is here.
two is ma'am, it's like it contains the axillary nerve and the posterior circumflex
Vessels.
humeral
Yes.
vessels. Yes,
3.
ma'am. And
Yes.
number 3 is ma'am auxiliary recess
What
containing
is auxiliary recess?
ma'am, it's actually it acts like like lower end of the shoulder joint. It acts like a bursa for this shoulder joint, ma'am.
Very good.
Auxiliary recess is a
Okay.
soft tissue, yeah.
Number 4, please.
Number 4 is ma'am scapular end of the clavicle.
Very good. 5, please.
Acromial end. Yes, ma'am. And 5 is ma'am the deltoid muscle.
Yes, please.
And
Good.
6
please.
is the glenoid cavity, and 7 is the glenoidal labrum.
Labrum. Yes.
8 is the head of the humerus. 9 is the supraspinatus muscle, and 10 is the supraspinatus tendon.
Excellent. Can you tell me what are the reflexes that you know of in relation to the upper limb or the shoulder joint, and how can you test them? What are the root values?
Yes, ma'am. It may at first biceps reflex. The root value is C5, C6,
yes.
And then triceps reflex mainly by C7, also sometimes C6.
Yes.
And there will be supinator reflex that will be also by root value by C5 and C6. And in case of biceps reflex, yeah, ma'am, should I interpret that?
Yes,
taking?
Yes, please.
In case of biceps reflex, ma'am, we'll ask the patient to hold the hand by the side and palm facing upward. I'll just put my thumb. I will just warn patient before that I'm going to tap over my thumb, and I'll just put my thumb over the biceps tendon in the cubital fossa, and I'll gently tap, and I'll look at the biceps muscle, ma'am, if there is any reflex contraction over there.
Very
and
good.
In case of triceps reflex, I will just I will do that, like I will hold the hand with my at the cubital fossa, like 90 degree abduction position, and also I'll just ask the patient to relax. Then I will tap over the triceps muscle. I will check for the reflex contraction of the triceps muscle. And in case of a supinator reflex, I will ask the patient to put his hand in the front of the body, like the palm facing his like the dorsum facing upwards or in the front. Then I will tap over the supinator tendon, like it is 2 to 3 inch, like 5 centimeter above over the lower end of the radius. I'll just tap over there. I'll look for any reflex supination of the hand or not.
Very good. Okay, yes. Can you please tell me what is the surface marking of coracoid process?
Yes, surface marking is actually lies 1.5 to 2 centimeter below and medial to the acromion process, like upper end of the shoulder, from the upper end of the shoulder joint.
Yes, approximately, yes. All right, can you tell me please the structures which are attached to the coracoid process?
Yes, ma'am. Actually,
all ligaments and muscles, everything, please.
Yes, ma'am. 3 ligaments over there, like coracoacromial ligament, coracohumeral ligament, and coracoclavicular ligament.
Very good.
And the muscle is about origin of the short head of the biceps and insertion of the pectoralis minor.
Very good. Okay. Bell has gone, but I wanted you to tell me the attachment and nerve supply and action of pectoralis major muscle, please.
Yes, ma'am. Actually, the pectoralis major origins from from clavicular end and sternocostal origin. And from the clavicular end, it's arises from the anterior surface of the clavicle, anterior surface of the clavicle of the medial half, actually, ma'am,
Medial
in
half,
case of
yes.
clavicular end, yes. And from the sternal end, it arises from the anterior surface of the sternum and also the costal cartilage of upper 6 ribs, actually. And it's inserted actually the lateral lip of the bicipital groove. And the function is, ma'am, when the whole muscle acts together, pectoralis major causes flexion and internal rotation of the shoulder joint. And in case of clavicular head, it flexes the shoulder joint, flexes the arm, actually. It flexes the arm. And in case of sternocostal head, it causes the extension of the flexed arm. And also it acts as the accessory muscles of respiration.
Yes, by elevating the ribs. Very good. Okay, yes. There are some plexus which are very much closely associated with the shoulder joint. Can you tell me which one?
Ma'am, brachial plexus.
Yes, can you tell
also
me the root
cervical
value?
plexus.
Yes.
Yes, ma'am. Brachial plexus arises from the ventral primary rami of the C5, 6, 7, 8, and T1, actually, ma'am. T1 now.
Okay. There are several injuries which are associated with the injury of the brachial plexus. Can you name two and tell me the differences, please?
Yes, ma'am. Actually, there may be Arps paralysis and Klump's paralysis. In case of Arps paralysis, it's mostly associated with the fall on the shoulder and fall on the shoulder, and it is caused by due to damage to the upper part, upper root value like C5 and C6, ma'am.
C6, good. What about the
and in case of Klump's paralysis, ma'am, it's mostly associated in case of child, in case of difficult breech delivery, and it's associated with injury to the C8 and T1. And in case of Arps palsy, there will be waiter tips position, like the arm should be adducted, the elbow joint should be fully extended and medially rotated, and there will be flexion at the knee joint, and the hand should be faced backwards. And this deformity is caused by Arps paralysis, and there will be loss of sensation at the radial half of the hand, arm and forearm, and also distribution of the radial nerve. There will be loss of sensation. And in case of Arps paralysis, mainly there is problem with the C8 and T1 level. So in that case, there will be clawing of the fourth and fifth digit, and there will be flexion of the interphalangeal joint and hyperextension of the metacarpophalangeal joint of the fourth and fifth digit, and there will be loss of sensation over the ulnar aspect of the forearm and the hand. In case of Klump's paralysis.
Very good. Yes, it's opposite on the other side. Very good. Excellent. Yes. Anyone who has any other opinion, come forward now. It was excellent. It was good. You could answer everything. Tremendous. And it was 100% surprise station. Well done. Yes, really.